So this is the summary of the malaria session. Okay, malaria session. I would like to highly recommend all of you to go through the malaria series, and this video is mostly for those students who are giving the exam. Okay. Malaria. Malaria is a protozoan disease transmitted by the female Anopheles mosquito. It is a pathogenesis species of the genus Plasmodium causes nearly all the malaria infection in the humans. Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, Plasmodium malaria, and Plasmodium knowledge. Plasmodium ovale are two types, sclerosis and voluntary. Death is mostly caused by Plasmodium falciparum, and the severe disease can be caused by the Plasmodium knowledge and Plasmodium vivax. The mode of transmission is by the bite of the female Anopheles mosquito. Infective form is exposed. Infective form to the mosquito is gametocyte infection. Infection of the blood of a malaria patient contain the asexual form, that is trophozoite-induced malaria. Trophozoite-induced malaria can be due to transmission malaria, is congenital malaria, malaria in the drug addicts. Okay. Over 55 species of the Anopheles mosquitoes can cause the malaria. Anopheles culciferis, Anopheles stephensi, Anopheles pulvitis, Anopheles culciferis is the vector of the Zula malaria, whereas Anopheles stephensi fancy in the urban areas, and Anopheles fluvitis is an efficient vector, highly anthrophilic. Okay, breed in the moving water, hilly areas, forests and the forest fringes. Anopheles sundecus, Anopheles ditus, Anopheles minimus, Anopheles philippensis, Anopheles magulates. Okay. The life cycle of malaria. The life cycle of malaria: female Anopheles mosquito inoculates the plasmodium exposure, blood stream to the liver, invade the hepatic parenchyma cells, that is intrahepatic preathocyte cytokine, and swollen liver cells burst and release the mesozoites. There is scriptozoites. Mesozoites invade the IVC to form the trophozoite, multiplied 6 to 20 fold every 48 hours, 24 hours, and 72 hours. When the parasite density reaches nearly 50 per ml of the blood, that is nearly 100 million parasites in the blood of the adult, symptomatic stage begins. Okay, exocytocytic cytokine is in Plasmodium vivax and Plasmodium ovale may remain dormant for 2 weeks to create the one ones. Dormant forms are called the hypnozoites, are the cause of the relapse, and lipidem is known as phanerozoites. Attachment of the mesozoites to the erythrocytes via the complex interactions. Okay, bind to the erythrocyte binding antigen 175 and glycogen A. Plasmodium vivax bind to the young cells stuffy blood group antigen for phenotype, which importance over subject and people with the positions in that areas are often negative for phenotype resistant to the Plasmodium vivax malaria. Intererythrocytic development, that is zinc form to the emerald form at the end of the erythrocytic cycle. The constituted of the RBC hemoglobin forms the hemoglobin pigment, cytokine or metacone, RBC rupture. Cytokine or metacone, RBC ruptures. Release of 6 to 30 daughter mesozoites, they can be converted into gametocyte or may infect the new RBC. Gametocytes are male gametocyte and female gametocyte. Female gametocyte is to male gametocyte 4:1 ratio. In the blood, male reaches the intestine of the female Anopheles mosquito. This gametocyte fuse to form the zygote, ookinete, where pinchette got wall and forms the oocyst. Oocyst expands by sexual division, was to liver to the migrate. Molar spores migrate in the hemolymph to the cellular gland of the mosquito, and with the inoculation for into the another human. Okay, at the next bit. To infect mosquitoes, the gametocyte should be mature, viable, and count greater than 12 per cubic meter of blood. Hosts involved in the transmission of malaria: female Anopheles mosquito, primary host, definitive host, sexual cycle, and sporocony. In man is the secondary host, intermediate host, and sexual cycle and cytokine. Epidemiology: Plasmodium falciparum, Africa, New Guinea, and Hispaniola. Plasmodium vivax, Central and South America. Both species equally in the Asia. Plasmodium malaria in the sub-Saharan Africa. Plasmodium ovale in the Africa less than 1%. Plasmodium knowledge in the islands of the Borneo and Southeast Asia. Endemicity has been defined in terms of the rates of microscopic detected parasitemia or palpation in the children 2 to 9 years of age. Classification: hyperendemic, major endemic, hyperendemic, and holoendemic. In hyper and holoendemic areas, repeated infection occurs in the childhood symptomatic disease, but if the child survives, so immunity is hard-won, infection becomes increasingly symptomatic. Older children and adults, major source of malaria transmission: stable transmission, constant frequent year-round transmission, unstable, low erratic or focal transmission. Hyperendemic areas, in these areas, symptomatic malaria can occur at any age. In the rainy season, the increased malaria breeding and the transmission principal determinants of epidemiology and normal of the vectors. Normal vectors in density: more mosquito, more malaria. Human biting habits: longevity of the Anopheles mosquito. Mosquito must survive for greater than 7 days to transmit the malaria because its sporocony in the mosquito lasts for 8 to 30 days. Its sporocony is not complete at the cooler temperatures. Okay. Pathophysiology. Pathology causes the erythrocytic changes, that is, invade the erythrocytes, contribute to the intracellular proteins, principally hemoglobin. Hemoglobin converted into hemoglobin. Heme is converted into hemogen, that is non-toxic product. Alters the RBC membrane, changing the transport properties, exposing the cryptic surface antigen, and inserting the new parasite-derived proteins. This result in the RBC becoming more irregular, more intelligent, and less deformable. In Plasmodium falciparum, membrane protuberance appear on the erythrocyte surface 2 to 15 hours after the cell invasion. These now sex with the Plasmodium falciparum EMB1. Mediate the attachment to the receptors on the venular and the capillary endothelium. Vascular receptors are in the brain are intercellular adhesion molecule 1, in the endothelial protein C, in the placenta chondroitin sulfate B, and in other against CD36. Cytoadherence, that is the attachment of in vitro RBC to the endothelium of the venous and capillaries, rosette formation, attachment of in vitro RBC to non-in vitro RBC, and agglutination, attachment of in vitro RBC to in vitro RBC. Cytoadherence, rosette formation, agglutination at the center to the pathogen sequestration during the vital organs, interfere with the microstructure flow and metabolism. Only young zinc forms seen circulating, as mature forms are sequestered. Level of peripheral parasitic may underestimate the true number of the parasites within the body. In other malaria, significant sequestration does not occur. Other issues of parasite development seen on the periphery of blood ischemia, Plasmodium vivax and Plasmodium ovale young cells, Plasmodium malaria old cells, old RBCs, Plasmodium falciparum and Plasmodium malaria both young and old cells. Host response, initially non-specific immune response, splenic immunological and filtration clearance functions are augmented. Removal of the both parasites and non-infected RBCs removes the damaged zinc from parasites, process known as splitting, and returns the one infected RBC to the circulation where the survival is certain. Parasitic cells discover the spleen removal, destroyed when the size and structure, material release, induces the monocyte macrophage activation, release of from the cytokines, leading to the fever and other pathological changes. Types of fever, quotidian, toxin, and quasin. Quotidian is daily, toxin means every 2 days, and quatin means every 3 days, seldom seen 2 days due to the prompt and effective anti-malaria treatment. Converse of protection against the falciparum malaria, thalassemia, sickle cell anemia, hemoglobin C and E, hemoglobin hereditary ovalocytosis, disease-free deficiency, non-specific host response, host defense that will stop the expansion of infection, and strain-specific immune response will control the infection. Strain and species specific immunity, cellular immunity, and the humoral immunity, IgM and IgA increase in the Plasmodium falciparum. Most important antigen is Plasmodium falciparum EMP1. Clinical features, non-specific features like fever, irregular, mainly the falciparum, greater than 104 degrees Fahrenheit, tachycardia, tachycardia and delirium, child febrile convulsions, headache, maybe shiver, but neck stiffness is absent, and photophobia is absent. That is signs of meningeal irritation absent, myalgia not as severe as in dengue, muscle tenderness not as severe as in leptospirosis, typhus, fatigue, nausea, vomiting, abdominal discomfort, orthostatic hypotension, mild anemia, palpable pain, sometimes hepatomegaly slight, and anemia children from the steroid transmission, mild jaundice not associated with the diabetic hemorrhage failure. Severe falciparum malaria, uncomplicated falciparum malaria that in which the patient can sit or stand unaided and can swallow the medicine and food. Mortality rate is less than 0.1%, but complicated falciparum vital organ dysfunction of the total proportion of the erythrocytes infected increases to greater than 2%. Mortality rate is steeply increases depending on the immunity of the host. Major manifestation of the severe falciparum malaria, major manifestations like CNS, unarousal coma, cerebral malaria, convulsions, lungs, pulmonary edema, ARDS, heart, hypotension or shock, metabolic acidosis, hypoglycemia, kidney renal failure, hematological severe normocytic anemia, bleeding or DHE, minor manifestation, hemoglobin urea, extreme weakness, hyperparasitemia, and jaundice. Complications like HAG, that is hypoglycemia, anemia, and convulsions are more common in children, whereas the jaundice, xenophilia, and pulmonary edema are more common in the adults and the pregnant women. Cerebral malaria, coma, characteristic and ominous feature, mortality even with treatment. Any obtudation, delirium, abnormal behavior in the falciparum should be taken very seriously. Diffuse symmetric encephalopathy more than the focal. Signs of meningeal irritations are absent. Eyes divergent, bruxism and port reflex are common. Other primitive reflex absent. Coronary reflex preserved. Muscle tendon reflex increased or decreased. Tendon reflex variable. Plantar reflex flexion or extension. Abdominal and chemistry absent. And flexion or extension posturing. And on fundoscopy, nearly 15% of retinal hemorrhage plus pupillary dilation. Convulsion fever. Convulsion fever is more common in the children, repeated tonic-clonic eye movement, or even hypersalivation. Neurological sequelae more common in the children, and nearly 10% have the persistent language deficit. Second is the hypoglycemia, poor prognosis, more common in pregnant and children due to the failure of the hepatic gluconeogenesis and increase in the consumption of glucose by both the host and to a lesser extent by the malaria parasite. Quinine can add to the hypoglycemia due to the power stimulation of the pancreatic insulin secretion. In severe disease, clinical diagnosis of hypoglycemia is difficult because usual physical signs are absent, and neurological impairment caused by the hypoglycemia can be distinguished from that caused by the malaria. Acidosis, poor prognosis factor, respiratory distress due to the anaerobic glycosis in the tissue, lactate production by the parasites, failure of the hepatic and renal lactate clearance. Plasma concentration of bicarbonate of lactate are the best biochemical prognosis in the severe malaria. On non-cardiogenic pulmonary edema, unclear pathogenesis, mortality rate is greater than 80%, precipitate the severely overly vigorous administration of IV fluid, pregnant more than adults more than in children. Renal impairment, AKI in the severe falciparum malaria, unclear but maybe due to the erythrocyte sequestration and agglutination interfere with the renal microcirculation, clinically as acute tubular necrosis. Hematological manifestations: anemia, isolated RBC removal by the spleen, RBC destruction at the cytogony, infertility, isolated RBC removal, both infiltrated as well as uninfiltrated RBCs are removed, degree of deployment correlates with the prognosis and development of anemia. Acute hemolytic anemia plus massive hemoglobinuria can lead to the black water fever and renal injury. Sudden hemolysis may follow many days after the additional treatment because of the removal of the treated RBC. Slight coagulation abnormalities in the falciparum, mild thrombocytopenia, or normal platelet counts to raise the question about the diagnosis of the malaria. DIC bleeding abnormalities in less than 5% of the patients, hematemesis from the ischial like acute gastric erosion. Liver dysfunction, mild hemolytic jaundice, in more adults than in the children. Just from the hemolysis, hepatic injury, cholesterol, liver dysfunction plus other vital organ dysfunction is a poor prognostic factor, whereas the other liver dysfunction without other vital organ dysfunction is a good prognostic factor and contributes to the hypoglycemia, lactic acidosis, and impaired drug metabolism. Other complications: predisposition to the severe falciparum malaria by HIV/AIDS or malnutrition, anemia worsened by the concurrent anemia, septicemia by the Salmonella species, chest infection can induce UTI in the patients unconscious for greater than 3 days, especially pneumonia following generalized convulsions. Malaria in pregnancies: in the high malaria transmission, primary and secondary gravidia women, low birth weight, average reduction is nearly 170 gram, increase in the infant mortality rate. Okay, HIV predisposes to more frequent and higher density malaria, congenital malaria, and exacerbates the reduction in the birth weight. But in the unstable transmission, mothers are also symptomatic with the anemia, hypoglycemia, acute pulmonary edema. This results in the fetal distress, premature labor, and stillbirth. Congenital malaria in less than 5%, and maternal death due to the malaria-induced anemia. In contrast to the plasmodium falciparum, in plasmodium vivax, multigravidia greater than primary gravidia, the reduction is nearly 110 gram. Okay, malaria in the children, hypoglycemia, anemia, and acidosis and comal convulsions are common. Transfusion: malaria through the blood transfusion, nearly organ transplant, needs malaria, no erythrocytic cycle, so incubation period is short, no role of the radical care even in the plasmodium vivax and plasmodium ovale infections. Chronic complication of malaria: hyperactive malaria, splenomegaly in malaria endemic areas, hyperactive because of the production of cytotoxic IgM antibodies to the CD8 plus T lymphocyte, antibodies to the CD5 plus T lymphocyte, increase in the ratio of CD5 4:to CD8 ratios, and uninhibited B cell production of IgM and formation of cryoglobulins, lymphohyperplasia, and clearance activity, leading to splenomegaly. Clinical feature as abdominal mass or dragging sensation in the abdominal causing sharp abdominal pain, anemia, and vulnerability to skin and the respiratory infections. Prevention: in the endemic areas by the anti-malaria chemoprophylaxis, and in the non-endemic areas by the anti-malaria treatment may be mistaken for the hematological malignancy, quatermaria nephropathy, chronic or repeated infection with the plasmodium malaria, focal segmental glomerulonephritis. Two patterns are present: coarse granular and the fine granular patterns. Okay. Burkitt's lymphoma and the Epstein-Barr virus infection, malaria-related immune dysfunction provokes infection with lymphoma virus, and Burkitt's lymphoma is strongly associated with the Epstein-Barr virus infection. Prevalence of childhood tumor is high in the high malaria transmission in the Africa. Diagnosis of malaria: patient with from the Malaysia, thicken is thin blood smear prepared, negative point examined by the experienced microbiologist does not have malaria. Thick blood film procedure: okay, uneven in thickness, unfixed, and a sexual parasite per 200 WBCs are counted. Okay, count gametocytes separately. Okay, and thin blood stain is fixed. RBC contain the asexual parasites per 1000 RBCs. And in severe malaria, this is the stage of the parasite development. Count the neutrophils contain the malaria pigment. Count the gametocytes separately. Okay, Plasmodium falciparum is student protein 2, dipstick test or card test. Okay, monoclonal antibody capsule test. Okay, obtained as a colored band. And Plasmodium LDH dipstick test. Okay, monoclonal antibody test, but 2 colored band, 1 band for the genus and 1 band for the species. And LDH and the aldolase common to all the Plasmodium species, and histone is protein 2 antigen specific for Plasmodium falciparum. Okay, microtube concentration method with the acridine orange staining. Okay, use of fluorescent microscopy. Okay, use of fluorescent relation from between the parasite density and the prognosis. Increased mortality at greater than 100,000 per ml, high mortality at greater than 500,000 per ml, and greater than 20% of parasite identified as pigment contain neutrophils and cyzones. Greater than 5% neutrophils contain the visible malaria pigment. In Plasmodium falciparum, the gametocytemia peaks 1 week after the peak of the asexual parasite density because the mature gametocytes of Plasmodium falciparum are not affected by the most antibody treatment. Their persistence does not constitute the evidence of drug resistance or need to retreat. PCR is more sensitive, but it is impractical, and it is used only for epidemiology. Ultrasound PCR and RDT is rapid and simple, but less sensitive. Laboratory diagnosis in acute malaria: RBC is less than normal side normochromic anemia, platelets is less, lymphocyte less, eosinophils less, ESR, CRP, plasma viscosity is increased, bond creatinine, electrolytes, WBC, and urine analysis are normal. Whereas in the severe malaria, prothrombin time, paracetamol time, and platelets prothrombin time and paracetamol tests are increased, platelets is decreased, and all the electrolytes are decreased, whereas the lactate, bond creatinine, urea are increased. Okay. In the cerebral malaria, the CSF pressure increases to nearly 160 mm of water, but the content is normal, and protein levels and the cell counts are slightly elevated. Treatment of malaria: uncomplicated malaria, non-sensitive strains of Plasmodium vivax malaria and the oval and the Plasmodium by the chloroquine, radical treatment by the primaquine. Plasmodium falciparum malaria: artesunate plus sulfadoxine or pyrimethamine, or artesunate plus amodiaquine, or artemether-lumefantrine, or artesunate plus mefloquine, or dihydroartemisinin valproquine. Second line treatment: artesunate or quinine plus one of the following: tetracycline, doxycycline, clindamycin. Severe falciparum malaria: artesunate or if unavailable artemether, or if unavailable quinine dihydroquinone, or if none of the above are available, quinidine. Pharmacology of anti-malaria drugs: chloroquine is the largest volume of distribution, accumulates the food vacuoles of the Plasmodium, prevents the polymerization from heme to the hemozoin. The adverse effects are the hypotension, auditory impairment, myocardial depression, most important is retinal impairment that leads to bullseye maculopathy, safe in pregnancy, bitter taste, but well tolerated. Quinine mechanism of action is unclear, and 70% plasma bound, especially alpha-1 acid glycoprotein. Okay, diisomer is quinidine. Adverse effect is hypoglycemia, can be prevented by administering it with 5% of dextrose. Chinchonism: at toxic dose, cardiac conduction abnormalities, quinidine more than quinine, hemolysis in GCPD deficiency patient, very bitter taste, and safe in pregnancy. Mefloquine, okay, can cause cardiac conduction abnormalities, psychosis, and seizures. Administration with the haloperidol of quinine contraindicated because it can cause prolongation of QT interval. Primaquine forms a redox compound that acts as a cellular antioxidant. Tissue cyzonicide and gametocyte always used with the blood signifier for the radical cure. Advanced methemoglobin hemolysis, and it is contraindicated in pregnancy. Antifoliate drugs like pyrimethamine, prog-1 sulfadoxine, and dapsone, slow acting blood cyzonicide, and adverse effect is megaloblastic anemia, pancytopenia. Ditovaquine, rapidly acting blood cyzonicide, collapse of parasites membranes. Okay, artemisinin derivatives like artemisinin, dihydroartemisinin, artesunate, artemether, and artether obtained from the Chinese of artemisinin annua. Artemisinin is a prodrug, and it is activated to dihydroartemisinin, which is active compound, highly active free radical that damage the parasite membrane, fastest acting drug against the malaria. The haloperidol and the lumefantrine. Haloperidol is potentially seriously cardiotoxic. Okay, when lumefantrine absorption that markedly increases with the fatty food. Severe malaria, artesunate drug of choice, artesunate given IV but not but can also be given IM. Artesunate gets an artemether and arteether because artesunate reduces the mortality. Rectal formulations are also available. Okay. Severe malaria is a medical emergency requiring the ICU and alternative treatment should not be used. And artesunate does not require the dose adjustment in liver and renal failure. If artesunate is unavailable and artemether quinine or quinidine is used, initial loading dose will be given, okay, but it should be given under the rate control infusion to prevent the dangerous hypotension. Okay, if not possible, quinine by deep IM injection into the anterior thigh. If the patient remains seriously ill or in the acute renal failure for greater than 2 days, maintenance dose of quinine or quinidine should be reduced by 30 to 50% to prevent the toxic of drug. For convulsions, IV or rectal benzodiazepines should be given. Can be given. For unconscious patient, the blood glucose, parasite count, renal function should be checked, and the fluid management should be done. It should not be overhydrated or underhydrated. Nasogastric feeding should be delayed in non-intubated patient to reduce the aspiration pneumonia. Band-aid therapy should be shifted to oral therapy. 3 days of course of ACT. Mifloquine should not be used as follow-on treatment for the serious malaria because of the increased risk of post-malaria neurological syndrome. Uncomplicated malaria patients should be monitored for vomiting for 1 hour after administration of any anti-malaria drug. With vomiting, repeat the dose. Fever, if fever is present, paracetamol should be given. Minor CNS reactions common, and mifloquine neuropsychiatric reactions. Okay. In pregnancy, the primaquine is contraindicated. So if infected by the Plasmodium vivax or the Plasmodium ovis, or prophylaxis with the chemoprophylaxis or with the chemochloroquine until the delivery, after which radical treatment can be given. Management of the complication mainly by the hemofiltration of acute renal failure, by the hemofiltration hemodialysis, acute pulmonary edema, by as other pulmonary edemas. Hypoglycemia by the dextrose and sepsis condition deteriorates during the antimalaria treatment. It can be due to hypoglycemia, the sepsis, and sepsis is mostly caused by the salmonella, and the antibiotics covering these species should be given. Antibiotics should be considered for the severely ill patients of any age who are not responding to antimalaria treatments. Other complications can be spontaneous bleeding, convulsion, especially pneumonia, and they should be managed accordingly. Prevention of the malaria by short-term chemoprophylaxis by doxycycline, long-term by the mifloquine. Doxycycline begins 1 to 2 days before the travel to the Malaysia. Take daily at the same time each day while in the Malaysia, and for 4 weeks. Mifloquine begin 1 to 2 weeks, take weekly, and for 4 weeks. Chloroquine 1 to 2 weeks, take weekly, and for 4 weeks. Whereas the atovaquone program, that is Malarone, begins 1 to 2 days, take daily, and for 7 days. Vaccine is Mosquirix RTS, yes, and it is a recombinant protein-based vaccine. Efficacy is 26 to 50%. Okay, it is made by pre-retrocytic circumscribed protein of the Plasmodium falciparum malaria parasite and a viral enveloped protein of the hepatitis B virus. Personal protection, avoidance of exposure to the mosquito at the peak feeding time, and use of DEET and insecticide treated nest. Okay. Incubation period, worm, that is falciparum vivax oval malaria, 12, 14, 17 and 28 days. Retrocytic cycle 48 hours, 50 hours and 70 hours. Recurrence is present in falciparum and malaria. Relapse is present in vivax and oval. Red cell prevalence we have already discussed. Morphology, Plasmodium falciparum, 3 types of ring forms are present: multiple ring forms, ecoliform and double ring forms. Crescent or banana shaped gametocyte. Plasmodium knowledge similar to the Plasmodium ischiumosal type present in Plasmodium vivax and Plasmodium oval. RBC size is enlarged in the Plasmodium vivax and Plasmodium oval. Others normal. RBC shape is oval in the Plasmodium oval. Others normal. Okay. Management measures in the pre-eradication era was mostly from the clinically diagnosed malaria. Classical management measures are spleen rate, average enlarged spleen, and parasitic rate. Spleen rate is the percentage of children of 2 to 10 years showing the enlargement of the spleen. Index used for the measuring the endemicity of malaria in the community. Average enlarged spleen, parasitic density, parasitic rate. Okay, infant parasitic rate is the percentage of infants of the age less than 1 year showing the parasite in the blood film. Is the most sensitive index of the malaria transmission in the community. If the infant falciparum rate is 0 for the secondary, it is regarded as absence of malaria transmission. Propagation case rate And malarial measures in the eradication era, their microscopic diagnosis of the malaria cases became the main method of diagnosis. Okay, annual parasite incidence, sophisticated measure of the malaria incidence of the community, and annual blood examination rate, annual falciparum incidence, slight positivity rate. Slight positivity rate means percentage of slides found positive for the malaria parasite irrespective of species, whereas the slight falciparum rate means positive for the Plasmodium falciparum. The vector indices are human blood index, that is a proportion of freshly fed female anopheles mosquito whose stomach contains the human blood, that is indicative of anthophilism, and the exposure rate, percentage of female anopheles with exposure in the salivary glands, mosquito density, number of the mosquitoes per man per hour of the catch, man biting rate, average incidence of anopheline bites per day per person. Okay, and an inoculation rate, man biting rate multiplied by infective exposure rate, and these rates are employed in the quantitative assessment of malaria and in building up a composite epidemiological picture of the malaria. Thank you.